Good evening, everyone. My name is Michelle Stecklin. I'm a product specialist here at Oculus. Welcome to tonight's clinical webcast, Navigating the Dry Eye Maze. You have a text box on your GoToWebinar screen where you can enter questions. Feel free to enter your questions during or immediately after the presentation, and we will have some time to discuss them at the end of tonight's webcast. Our speaker tonight is Dr. Paul Karpecki. Dr. Karpecki received his Doctor of Optometry degree from Indiana University and completed a corneal fellowship in Kansas City in affiliation with the Pennsylvania College of Optometry. He currently serves as Director of Cornea Services for Kentucky Eye Institute in Lexington, Kentucky, and for the Gaddy Eye Centers in Louisville. In 2017, he completed a full-year preceptorship in advanced retinal disease at Retina Associates of Kentucky. He also serves as an associate professor at Kentucky College of Optometry in Pikeville and is the medical director for Kepler Vision and the Dry Eye Institutes of Kentucky, Indiana, and Colorado. Dr. Karpecki was appointed to the Delphi International Society, which included the top 25 dry eye experts in the world. He co-chaired the Dry Eye Summit, was selected to the Tear Film and Ocular Surface Society DEWS II Diagnostic Methodology Subcommittee, and appointed co-chair during the most recent Tear Film and Ocular Surface Society Symposium. He served as co-chair of the Dry Eye session at the Ophthalmic Innovation Summit during the American Society of Cataract and Refractive Surgery in 2018. And co-chair of the inaugural Ophthalmic Innovation Summit in New Orleans. He currently serves as the Chief Medical Editor for the Review of Optometry and is on the board of the charitable organization Optometry Giving Site. It is an honor to have Dr. Karpecki with us tonight for the webcast, and on behalf of Oculus, I would like to express our gratitude for his time and effort. I would also like to thank you all in attendance tonight for your time. Without further delay, I would like to welcome Dr. Paul Karpecki.
Thank you, Michelle. Wonderful introduction. I really want to thank everybody for being on the call. I know we are at a busy time, lots going on in life. It says a lot about you making time to be on this webinar. And thank you to Oculus for providing this educational opportunity to the professions in terms of understanding dry eye. And I thought with the title of Navigating the Dry Eye Maze, the best way I could do this was to try and find some clinical applications of an expert consensus guideline. And the most recent expert consensus guideline, of course, was TFOS, Tear Film and Ocular Surface Society, DEWS II, Dry Eye Workshop 2. And I thought that might make sense to look at that as our approach. So let's begin with the first slide, Michelle. If you look at ocular surface disease, the most common ocular surface diseases that we face in eye care, optometry, ophthalmology, is truly dry eye. And if you think about some pretty amazing statistics, 90 million people probably have dry eye based on signs and symptoms. And if you go to the next slide, you'll see that 30 to 50 million people report having dry eye disease. And this is based on what we call longitudinal studies, where you look at a large patient population that were involved in these two things, Beaver Dam and the BOSS. BOSS was actually the Beaver Dam offspring study. They took a look at the children of the people in the Beaver Dam study and found that about 30 million people had dry eye. What's really fascinating, though, is only 16 million are diagnosed. If you look at ICD codes, ICD-10, each year it's only about 16 million. That's a big number. I mean, you think about glaucoma, that's 3 million. But still, if there's 30 to 50 million people, only 16 million are being diagnosed. That's a fascinating number. And the most intriguing thing is, how many do you think of those patients are currently being treated? And that means a drug that has a labeling for dry eye disease, of which we have 3 known drugs, maybe 4. And the end result, as you can see on the next slide, is just 1.5 million people. So it means that if there is really 90 million people out there, we have a lot of learning and a lot of opportunity to advance. If you speed up to a couple of slides ahead, Michelle, you'll see that the ocular surface disease as a whole really probably encompasses a much larger population. 42% of all comprehensive eye exams involve a complaint that's related to dry eye disease. So if you think about a patient calling into your office and has a significant complaint or whatever their chief complaint is, 42% of the time it's going to be something like eye dryness, fluctuating vision, symptoms that you think about. And since optometry performs about 88% of all comprehensive eye exams in the United States, that becomes a very significant population of the dry eye population that we're going to see on a regular basis. And so it really does warrant this concept, today's title, of navigating through the maze. If you go to the next slide, you're going to see that we're going to go into a definition. This is the TFOS 2 newest definition that came out around dry eye disease. Next slide. It's a multifactorial disease of the ocular surface. It's characterized by a loss of homeostasis of the tear film, accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play an etiological role. That's a big statement, sentence, hard for me to even understand. But if you dissect it, you're going to find there's a lot of value to here. We already know it's multifactorial. There's a lot of causes. I remember when I started working in dry eye, which was in the mid-1990s to late 1990s. I'm still shocked by how long I've been at this and how unsuccessful I've been for the first maybe 8 to 10 years for sure. But during that time, I remember a individual approaching me and said, you know, if you think about the future of dry eye, and I'm glad you're in this field, think about the acronym WOMAN, because women at that time obviously had a lot more dry eye disease. Now, if you look at some of the research today, you'll find that, you know, if you look at populations between age 21 and 34, there's really actually no difference between men and women when it comes to dry eye. That's probably because of digital devices. But back then, 1997, he said, think about women, W being water, which is our aqueous, O being oil, which is now something we talk a lot about, which is lipids, M being mucin, which is actually not a component we think about, although there truly is mucin deficient dry eye. I see it all the time in my clinic. A is androgens, again, something really important to TFOS dues to report, but not something we have a treatment for. And then N is nerves. And we're finally understanding the role of neuropathy and keratitis involving nerves and how that plays a role, trigeminal stimulation, et cetera. So it's amazing that that individual who told me that over 20 years ago was so prophetic into where we are today. And this definition started to take that into account. We're talking about dry eye, you have to have signs and symptoms. You have to have hyperosmolarity because it's a change in the osmolarity of the tears that ignites everything, including inflammation and damage. But I'm glad to see neurosensory being involved in the definition. In the next slide, you're going to realize that dry eye is not an isolate. If you look at the Lacrimal functional unit, this is a term that was, I think, first quoted by Steve Flugfelter, the fact that everything works together. Your tear film, lacrimal glands, cornea and conjunctival epithelium, and meibomian glands are all intertwined. And the homeostasis of this is controlled by nerve connections and hormones like androgens. So if you look at even this research, Berabino's research, the first coined discussion of this whole lacrimal functional unit, you'll realize that it's all connected. Why is this important? Well, it's important because we used to think of dry eye disease as being one thing, and that was probably right, but we didn't understand a lot of its intricacies. And now we started thinking later on that you had aqueous deficient, which is where you don't have enough water, or aqueous, and lipid deficient, also known as evaporative dry eye, where your meibomian glands aren't functioning. But the fact is, and Don Korb has shown this for many years too, that if you have lacrimal glands that aren't functioning, your meibomian glands have to make up for it, and eventually they burn out. It's like running a marathon every day, and they eventually can't keep it going. And so it is amazing how you can have some of your worst meibographies, a lot of atrophy, in a person who has Sjogren's syndrome, meaning these conditions are not isolated. There may be a time where aqueous deficient is alone aqueous deficient and meibomian gland dysfunction, evaporative dry eye is alone, but over time they all start to connect. Now, patients come into my office and they often have really advanced disease. I have almost 500 lab tested or biopsy positive Sjogren's syndrome patients in my clinic. I'm sure there's other clinics that may have numbers near that, but there can't be many of them. We really focus with a very, very subspecialized group. And although that doesn't mean you don't want to pay attention to this webinar, you might say, wow, that's a different place and maybe it doesn't apply to me in clinic. It really all does apply, because my goal is that patients don't show up in a clinic like mine, that we're treating them at the earliest stages, that we're not allowing progression of all of these lacrimal functional units because we're not addressing disease at the beginning. When these patients come into my office and they're down to their last 4 glands and they've got scarring on their cornea, neovascularization, they all say things like, could my eye doctor have done something sooner? And I'll tell you, the fact is, the answer is probably no. You kind of get a pass. If you look at the next slide, this is the dysfunctional tear syndromes clinical categories. And I got to give credit to this group too. Back in 2001, we met together at Johns Hopkins, and this group did a really good job. These were considered the top 25 experts in dry eye disease based on number of publications, seeing a lot of patients, and they put them all in a bust us over to this place at Johns Hopkins. We all had to come up with these consensus guidelines. And the reason I say this is not to put down any group, because this group was very brilliant. I mean, who was talking about lid margin disease much other than maybe Don Korb and a few other people back in 2001? We really didn't even think about the importance of lid margin, expressing Meibomian glands, and trying to change dry eye to dysfunctional tear syndrome. But if you look at the abstract, which was published in 2006, so that's 13 years ago, maybe 14, since we're almost at the end of the year. If you think about that, the abstract said the most common presentation for dry eye disease involved no lid margin disease. That means the top 25 people in the world 13 years ago were completely wrong. They really, if this group, who were the experts, and again, I'm not putting down a group, I was in this group. If they could be that wrong, how could every doctor who manages dry eye have known what to do? So the point of this slide is to say that this group was critical to advancing dry eye disease and understanding. But the fact is, if they could even get the most common form of dry disease, 86% of dry disease involves the lid margin, then we all have a pass. We didn't know enough 13 years ago. We didn't know this disease was so progressive. That being said, if you listen to this webinar tonight, you don't have a pass anymore. You have to realize that this is a progressive disease that continues to advance, and they'll end up in a clinic like mine if you don't manage it early. And you can prevent all of that by being involved, by understanding this, and by treating the dry eye disease. The next slide is just kind of a past slide that kind of shows a tear breakup time that's fairly significant. It makes you wonder, what do we do to look at dry eye disease? How do we manage this? What are our options? Well, the first thing that I realize is that dry disease has really changed. So if you advance a couple slides for me, Michelle, you'll see the prevalence of dry eye has changed in terms of age and gender. This first slide here that has the yellow bars and the red bars actually shows that the incidence of dry eye is much more common in women and much more common after about age 55. And the facts are that that's not necessarily what we know today. This was the Beaver Dam study. This is more than 15 years old, and that was accurate back then. But I want to show you something quite compelling. In the next slide, you're going to see what's called the BOSS study. This is the Beaver Dam offspring study. These are the children of the slide we just presented. And if you look at this group, what's really fascinating to me is that the incidence of dry eye between men and women age 21 to 34 is statistically the same. That means there's just as much dry eye in men as women at a younger age. Average age of onset of symptoms is about age 27. This is now a young person's condition. And maybe it is because digital devices came along 10 years ago. Smartphones only 10 years old, roughly. And I don't think smartphones are going away. I don't think tablets are going away. Obviously, digital devices are not. So we're going to see a lot of dry eye. This really will take over any other pathology we can manage. And so it behooves us to be very involved in this and to be able to manage these patients because of the impact they'll have on our clinic. The other thing that's really fascinating to me is that if you look at the bottom, it says dry disease prevalence is similar in both younger and older populations. The incidence in dry eye of the children of the Beaver Dam study was statistically the same as their parents. So we are seeing dry disease at an earlier age, equal in men and women up to the perimenopausal age category, and equal to the older population generation. So this is something that's going to impact everything you do. It's going to be the number one reason for dropouts in contact lenses, which costs optometry $3.3 billion every year, dropouts. You got to think about it. 10% of patients drop out. There's 44 million people, or sorry, it's 18% of patients drop out of contact lenses a year. There's 44 million contact lens wearers. That's 10 million people. If you assume a very modest income per contact lens, modest revenue of $330, that's $3.3 billion. And I know contact lens patients generate more than that per practice per year. So it's the number one cause of remakes. There's a study to be published on that. So it's the number one cause of IOL miscalculations. Alpha-Metropolis showed 17% of patients going in for a premium IOL or any IOL procedure would miss their intended correction by more than a diopter. Can you imagine paying a premium to have an IOL put in and you end up being +2 after your IOL's in? You have no chance of improving that. You can't. Surface PRKs don't work as well as you'd like. You can't take that lens out, all because someone missed the dry eye. What's fascinating about our study is the people who didn't have hyperosmolarity, who didn't have dry eye, 100% of them were within a diopter of intended correction. It just goes to show dry eye impact, spectacle remakes, contact lens dropouts, IOL calculations, pretty much everything that goes on in a practice. So let's take some time, as you see in the next slide, to go through TFOS Do's, To's recommendations. I doubt many people on this call have read every page of TFOS Do's, To in all 11 sections. To be honest, I was on the diagnostic committee. I reviewed some of the area, and I haven't read all of it. So it's not something I'd expect, but I'm going to try and save you reading 300 pages by taking you through some of the summaries that are provided, and I encourage you to read those and tell you what we're looking at, what came out of that. I think it is very practical this year. I mean, when they published this, I think it had a lot of value to a clinician. So if you look at a patient who presents in your office, I'm going to break this down. There's one of two ways that we can diagnose it. Number one, they're asymptomatic. And if they're asymptomatic, but they have a lot of staining, that means signs of ocular surface disease, and you look at, they have grade 3 staining, minimal tear meniscus, and they say, yeah, my eyes aren't really bothering me other than I can't see. That's called a neurotrophic keratitis. And the good thing about that is that these are patients with a lot of stain but no pain. They essentially look terrible but don't even realize it. I had one today who was a patient with long-standing diabetes, and I mean literally 20/40 vision. That's why she came in. Grade 4 SPK, conjunctival staining, Meibomian glands that wouldn't produce anything. And she said, well, I know I'm bad, but I don't really feel it. And I tested her. I took a little dental floss. That's my favorite little diagnostic for testing nerves. I touched the inferior cornea, and that's got to be kind of the old-fashioned acrylic dental floss, not like the minty new stuff, but touch her in the inferior cornea, and no sensitivity at all. This filament was bending. She had no idea. And so she was classic for a asymptomatic, tons of signs, neurotrophic condition. And if they're asymptomatic with no signs, obviously, then you're looking at a other cause that may play a role, or asymptomatic, no signs, maybe even normal, as you see there. If you go to the other side, where they're highly symptomatic and they have no signs, way over on your right, that's called neuropathic dry eye. This is one of the toughest, neuropathic complex pain, not dry eye. It can be caused by dry eye long-standing, but typically is more of a nerve complex damage system, where patients have had this for a long time. Their nerves have downregulated. Now they just don't function. In fact, if you do confocal microscopy on these patients, their nerves don't look normal at all. They bend, and they have branches, and they're really atypical, and they start sensing airflow and temperature changes and all kinds of stuff. So they're chronically in pain, but they have no stain. They have no signs. These are a tough patient population. So really dry eye, which we're going to deal with today, is that category to your right that says symptomatic but has signs. And then we're going to go through today what you should be looking at. So if they have signs and they have symptoms that tie into dry eye, and they don't have predisposing factors, then we're going to talk about how do we test, how do we determine what type of dry eye disease is it? Is it evaporative? Is it aqueous? Is it mixed? And if you look at the next slide, I'm going to take you through one component you need to know first. And I think this next one is really a component that separates the best clinicians when it comes to managing dry eye. And that is the patient who has symptoms of dry eye disease, but ocular surface disease differentials come in, meaning it could be other things. So if you advance to the next slide, you'll see that ocular surface disease differentials are quite vast. And here's a good number of slides that can represent that. So here's the person who presents in your office. They have dryness, grittiness, irritation. You're thinking that's got to be dry eye. You do an osmolarity and it's normal, 292, 291. So now you're thinking, gosh, what could that be? You start looking at the eye to figure out, is this dry eye? Rather than treating them with a dry eye drug for 6 months and not getting anywhere, you're starting to say, okay, let's look at what this can be. And here's a few images that you'll see in the next slide that cover epithelial basement membrane dystrophy in the upper left-hand side, GPC in the top image, Salzman's nodular degenerations, conjunctival chalasis off to your left, and just medicamentosa, as you see there in the bottom right-hand. So these are just an sampling of patients who might have symptoms that sound like dry eye, and yet they're not. I have days in my clinic. So today we had a busy day, not our worst day, but we had 56 patients. Have a really good team, so we can get through patients very efficiently. And as I was looking at a lot of the new patients, what was fascinating is that I only had, like, out of about 10 new patients today, maybe 2 that had dry eye. Everybody else had conjunctival chalasis, Salzman's nodular degeneration, epithelial basement membrane dystrophy, and they've been treated for the last 2 or 3 years with dry eye medications and are not improving. This is what's going to separate you as a phenomenally good clinician is when you can start to differentiate the non-dry eye conditions. In the next slide, you're going to see a sampling of some of the conditions that have symptoms of dry eye disease, normal osmolarity, and minimal signs, meaning you express and there's not much there. And you can go through the builds here, Michelle, so the whole slide comes up. It'll include dry eye disease that's well controlled, contact lens solution related, mild allergic conjunctivitis. A big one's epithelial basement membrane dystrophy. These patients can get dryness and all kinds of problems. In fact, I noticed one of the anchors from Fox News who was almost suicidal with dry eye because she'd suffered with it for such a long time, said she'd seen about a dozen doctors. Imagine 12 doctors. She never came to my clinic, unfortunately, but she did go to a practice in New York City where she was finally diagnosed, and she talks about them all the time. It turned out she had epithelial basement membrane dystrophy with recurrent erosion, and that's why she'd suffered, and everybody was treating her as having dry eye. So if they had been at this webinar, those 12 practices, and listened to this webinar, they had had some insights for taking care of this anchor woman, last name was Bream, for, as far as dry eye versus another cause, and may have been the heroic doctor to have helped her. Pinguecula, early pterygia, conjunctivitis, medicamentosa, mucin fishing syndrome. These are not dry eye. Limbal stem cell deficiency, Demodex blepharitis, and even many blepharitis, giant papillary conjunctivitis. Patients who have asthenopia, especially those with convergence insufficiency, will have a lot of symptoms of dry eye, even though they don't have dry eye. It's called trigeminal dysphoria, and you can measure for it. Salzmann's nodular degeneration. They say the epithelium over a nodule is about 10 microns, where it should be 50 to 100. Obviously, you're going to feel that. It's going to feel like dry eye, but it may not be. Conjunctival chalasis, where they have folds. You can put up that next row of slides there, Michelle. Conjunctival concretions, SLK, episcleritis, exposure, keratopathy, and even patients who have chronic staining will mess up osmolarity because it'll seem like a much lower number. But if you want to put up that next column of what I described, that would be really valuable. Here's an example in the next slide of a patient who came into my office not so long ago who had been treated for 5 years for dry eye. They'd had every possible drop you could imagine in their bag that they brought in. It was like a Ziploc bag. And I happened to notice this SPK, as you see there in the upper left-hand quadrant, at about 10 o'clock. So fortunately, it was obvious something was going on. Osmolarity measured 287, 288. And I thought, no, I don't think you have dry eye. I expressed to my Meibomian glands, it was pretty close to normal oil. So if they had dry eye, whoever had treated it did a great job because it was gone. Look at how high the tear meniscus is. It's very ample. There's no staining of the concha, no staining of the cornea, good lipids, normal osmolarity. Everything on my Oculus looked completely normal in terms of the meibography, tear meniscus height, and staining pattern other than up there. So I averted the upper eyelid, as you see in the next slide, and guess what's underneath there? A large concretion. And the concretion actually shows up with staining, as you see superiorly. And so obviously it was causing that foreign body. I removed that. I just took a 30-gauge needle after putting in topical anesthesia and just kind of broke the conch over top of that, and then with some forceps pulled out that large concretion. 2 days later, the patient calls in and says, "You guys are miracle workers. I've been dealing with this for 5 years. The first time my eyes no longer feel dry." And they said, thank you for what you've done. The fact is, we weren't really miracle workers. We just knew that if the testing tells us it's not dry eye, you got to look for other things that sound like dry eye. In this case, it was concretions. So let me take you through TFOS DEWS 2 recommendations, which is the next slide, for dry eye disease diagnosis. And I want to advance 2 slides, if you can, Michelle, which is to another diagram that TFOS DEWS 2 came up with that's in the diagnostic committee. And I love this. Although you look at it first, you're going to think, wow, that's awfully busy. I'm not sure exactly what it says. And credit to TFOS DEWS 2. They made their algorithm or their publication extremely practical. They involved clinicians. Like I was on one of the committees, and I wasn't on the committee the time before. And I don't have the brains of these researchers. I can't quote the studies to the level they do. These researchers knew stuff inside and out. But what was good about the TFOS DEWS 2 committee, especially my committee that I was on, I wasn't the chair, but I was on the diagnostic committee. James Wilson was the chair, is that they looked at all of these aspects and said, does this really apply to clinic? And in the end, they came out with this wonderful document, as you see here. that breaks down how to manage dry eye. And I'm going to save you reading about 70 pages in about the next 2 to 3 minutes and give you the algorithm for how you might treat or diagnose dry eye in your own clinic. So the first thing you want to look at, as you see there, is what's called triaging questions. If you go to the next slide, my favorite 5 triaging questions are, do your eyes ever feel irritated, dry, or burn? Number 2, next slide, are your eyes red? Number 3, do you experience blurred vision, especially fluctuating vision? Number 4, do you use or have the urge to use artificial tears? And then finally, number 5, how much time do you spend on digital devices? I tell you, if you have your staff ask these 5 questions during the history, you're going to start uncovering a ton of dry eyes. Basically, how do your eyes feel? How do they look? Do you have fluctuating vision, the urge to, or are you using artificial tears? And then how much time on digital devices? Anything over 2 to 4 hours is too much, typically, or a contributor or risk factor to dry disease. I love these 5. These actually came from the Optometry Dry Eye Summit in Denver, Colorado in 2014. So give credit to that group. And I think really I use this in my clinic and it identifies a ton of dry eye. In the next slide, you're going to see that you have to look for things like redness. One of the great things about the Oculus system is that it actually will give you exact redness measurements ahead of time. Not that you couldn't look at that at slit lamp, but there's great value to have it documented and put into your EHR. In fact, if you look at the next slide, this 43-year-old lady who you saw earlier was being treated. Oh, that's backwards. Go forward slides. Forward. The 43-year-old female was treated for MGD. You could see how much the redness improved in her eyes over time. Now, this is important because even though you feel like you're making someone's eyes better as you manage them, having pictures from before and after really become extremely telling and really put in perspective how much these patients improve. It's kind of like they say, if you took a frog, not that I ever do this, and put them in boiling water, they jump out. But if you slowly boil the water, they never move and they get baked, I guess, or boiled, whatever. But the point is, subtle changes are hard for anyone to perceive. So having pictures like this 9 months later, next slide, really help you to see what kind of improvement. It's another big technology advancement that is in the Oculus system. If you advance to the next slide after that, you will see what we're going to go into next. We're going to cover risk factors we kind of talked about. You know that someone who smokes is going to have more risk of dry eye. Someone with certain medications like allergy medications has more risk of dry eye, contact lens wearers. So you know the risk factors and you want to use that to suspect dry eye. But here's what's cool about the TFOS diagnostics is that you have to have, as they said in the definition, a symptom and a sign. So as far as symptoms, they say you should use a questionnaire, and I have to agree with that. It's amazing how few patients will tell you symptoms that they have. And I know you sit there and think, yeah, but my patients will tell me. I don't know. I've seen a study that looked at contact lens wearers. And in this study, it was over a decade ago, only about 10% of the patients told their doctor of symptoms they had related to dryness, contact lens intolerance, not as comfortable at the end of the day, issues that had indicated they were about to drop out of contact lenses in the next few years. 10%. When they did exit interviews, more than 80% of people on the exit interviews with questionnaires said that they had these symptoms. And you sit there and wonder, why would only 10% tell their doctor about symptoms? That makes no sense. That's what they're going to the doctor to see. The answers were amazing. The patient said things like, well, I didn't want the doctor to take me out of contact lenses. Or I thought it was normal to feel my lenses. I'm getting older. Or, yeah, I have some dry eye, but it's kind of what I expected to have. Or I don't have problems because I take my lenses out and I soak them for an hour in the middle of the day. Well, that's a problem. Or I don't have issues because I take my lenses out at 3 o'clock. Those are all things that didn't come out from the patient until they did the exit interview. So I think you do need to have a questionnaire. My favorite questionnaires, as you see in the next slide, are either the DEQ5, the OSDI, or what I use, which is the SPEED questionnaire. It's a very quick questionnaire. Takes patients literally 5 minutes. If you don't have more paperwork and stuff in the front area, then just have the staff ask the questions and tabulate it. And then you get in anything over 8. They say anything over 6 counts, but I use 8. I like kind of a higher bar. And Ben Gaddy is the one who kind of came up with that number for our clinics over there in the Kepler group. And it actually works better when we get up to 8, because then you have patients who truly have dry eye. Then you need to start looking at signs. So let's go to the next slide. These are the diagnostic tests for signs that are recommended by TFOS DEWS 2, and they recommend you do at least one. I'm going to tell you you should probably do two. And in this slide, what you're seeing, this next slide, you're seeing three choices: non-invasive tear breakup time, osmolarity, or ocular surface staining. So let me go to the next slide after that. Osmolarity, in my opinion, is the most accurate test I have for dry eye disease. I couldn't run my clinic without it. You have to have a technician who knows what they're doing in order to get the proper sample. It takes a little bit of practice, but once they do, this is the most valuable test that you are ever going to utilize. And there you see the sample. And it isn't that easy. The sampling actually is on the bottom of the tip. People think that they point the tip into the tear cup. That'll just cause tearing, and you'll get an abnormal number. You can actually place it on the tear meniscus, and the lower part of the little device is what reads the tears in about 5 seconds. So a lot of stuff. And patients who don't have dry eye truly are extremely stable. There's no change in their numbers, as you see on the slide. Patients with dry eye tend to be all over the place. Actually, go forward if you don't mind. Tend to go forward. They tend to have a lot more dry eye. The second thing that's recommended is surface staining. And you can see here a patient with a lot of patchy staining on their cornea. This is indicative of a person with also a very thin tear meniscus. You see there, indicative of Sjogren's syndrome, KCS. They typically have a very chronic kind of patchy staining appearance, just like you see in this image. Can you advance the image too, please? You'll end up seeing that. I think you went backwards, forward too. You see this next slide shows kind of the same thing. So one of the great things about the Oculus Kerograph is that so much of what you need for diagnostics is all in this one system. So there you have what's there. And yes, it does a lot of things. You can get the version that has topography in it. You can get a version, that has all the contact lens software, which is some of the best for scleral lens fitting, RGP fitting, etc. But I want to really focus on dry eye today. And one of the real values here is corneal staining. So remember, TFOS DEWS 2 recommended one of three tests: non-invasive breakup time testing, corneal staining, or osmolarity. I'd recommend you do two. So if you look at the staining pattern that's on here right now, what you're seeing is a great way of capturing it. And this goes right into EHR. So you're able to pick up on the individual staining. You're able to see the conjunctival staining, the corneal staining, all in one image. And I love the capabilities that are here and how well it is. You can also look at grading. You can put a graph on the front, a kind of an image component that looks at the 5 areas of corneal staining. This is wonderful for doing FDA trials and clinical trials, where you can actually break down the amount of staining per category and measure it. But that is also present there. You can do listening green staining to look for linum marks, as you see in the next slide. And in that, you're able to pick up on the degree of how much that is present. Listening green is a very good marker for the conjunctiva. And I'm a big fan of staining the conjunctiva in addition to the cornea, because I want to be able to pick up, mucin deficient dry eye and subtle signs of early dry eye that may be there. And again, these are all images that can be billed as external photography. So you very quickly get reimbursed for your technology, such as an Oculus Kerograph M5. And if you look at the next slide, which is non-invasive breakup time, I'm a huge fan of this. So is TFOS DEWS 2. If you look at their recommendation, this was the #1 recommendation for managing dry eye. The reason we went with a non-invasive tear breakup time is that there's so much variability when you try to put dye in the eye, wait the exact amount of time. I love this technology because, as you see there, the breakup red means it was very rapid within 5 seconds. You can see that the yellow was somewhere, within that 10, 12, and it's very accurate for where you're at. There was no green on this patient in this next slide because obviously they didn't have any normal areas of tear breakup time as you would expect to have. So wonderful test. And what's really cool about this, as you see in the slide afterwards, is that as you advance, you can see that the patient can improve over time with your treatment. And this is a wonderful scenario. Where you see the first image of breakup time, you see the second one, now we've got a lot of green. You see now that third one where everything is completely normal. And patients are blown away by this and obviously doing very well at this point. And you can see how the breakup time now becomes normal. And unlike trying to use a stopwatch or timing it or putting too much dye or too little dye in, this is a very accurate way of being able to measure it. So if you go back to TFOS DEWS 2, it says, okay, so this is the next slide. It says, once you identify dry eye. So one of the great things about osmolarity, non-invasive breakup time, or corneal staining, is that it tells you you have dry eye as a sign, especially when it's tied to a symptom questionnaire like speed. So now you get your symptoms, you've got your signs. If there's a fault of osmolarity or a fault of staining or a fault of tear breakup time, even these non-invasive ones, which I prefer, it's that it doesn't identify the type of dry eye. Is it aqueous deficient or is it evaporative? So in the next slides, what we're going to look at here is how do you determine the type? And there's two types of dry eye disease. There's primary evaporative dry eye, which is caused by Meibomian gland dysfunction. There's a form called aqueous deficient dry eye, as you know, which is your Sjogren's and your non-Sjogren's KCS. So those are our two primary subtypes of dry eye disease. So let me ask you, you did your breakup time, you know there's dry disease. That actually doesn't tell you if it's evaporative or aqueous deficient. A person with Sjogren's has a fast breakup time. A person with evaporative dry eye has a fast breakup time. They both have high osmolarity. They both have staining. So how do you differentiate the type? Because the treatment changes based on what you differentiate. And here's where the Oculus also comes in handy, because so much of what you're looking at is also in that technology. And so one way to be able to differentiate this diagnosis, to be able to look, if you go to the next slide, you'll see what we're going to talk about here. This is the subsection around, is it aqueous deficient dry eye or is it evaporative dry eye? So the way to tell if it's evaporative dry eye, that means the Meibomian glands aren't functioning well, is to do what? One thing you can do is express the Meibomian glands. That is, you can get a paddle like you see here, the scrotal paddle. You see I'm pushing on the glands. And you see that there's some lipid coming out that's not good. What should come out is like an olive oil. This is coming out almost turbid or paste-like, gelatinous, much too thick than it should be. And another way, as you see in the next slide, is also some expression that looks like toothpaste, telling us that that's not normal. And the slide after that is another great way of making a diagnosis, and that's meibography. What you're seeing here is the Oculus keratograph imaging of meibography of the upper and lower eyelid. If you saw an eye that looked like this, you'd be very pleased. They're not likely to have any sort of issues. They have all their Meibomian glands in place. They look like keyboard keys. They're all in place, very healthy, very long. If you look at the next slide, there's a person who I tried to express. Nothing would come out of their oil glands. And there's a big difference between someone who you try to express their glands. I mean, it only takes 5 seconds to push on those oil glands to see what's coming out. And if nothing comes out, the glands could all be there like the last image, which would mean they're really healthy but not functioning. Or they could be like this image in front of you, where 90% of them are missing. And obviously, I'm going to treat someone with 90% gland loss very different than someone with 5% gland loss. So meibography is critical. I consider this the OCT of dry eye disease management. And here again, if I'm looking at the upper left-hand image that you see there, of someone really healthy and normal eyelids, I'm going to treat that very differently than that lower right image I just showed you, where 90% of the glands are gone. As you see in the next slides, different presentations of patients who have meibography issues. You can see stress on some in the next slide. You can see significant missing glands. I mean, these are patients where you're down to only nubs left. And so many of these patients come into my office and say, you know, can my eye doctor have helped me sooner? And the fact is, we didn't really know this stuff sooner, but now we do. Now we have access to meibography. We know how to express lower eyelids. We know what to look for. We know how to come up with the right diagnosis. There's really no excuse for us in not treating these patients who have a very progressive disease known as dry eye disease. And you can see how it progresses over time, or what level of grading they have. Now, that's how I can tell if it's evaporative dry eye. And in evaporative dry eye, I'm going to focus on obstructed glands and inflammation and maybe bacterial biofilm. What if I had aqueous deficient dry eye? What if it was the Sjogren's type? You know, again, staining gives me a little bit of an idea of that. Osmolarity means it's high, which could be both forms. That makes it a very valuable test, but it may not differentiate the types. Tear breakup time is a very valuable test, but doesn't differentiate the types. How do I differentiate to know if it's aqueous deficient? Well, here's your answer. The assessment of the tear quantity tells you if it's an aqueous deficient dry eye, and that means the tear meniscus height. If you look at that tear meniscus height, you can actually, in the Oculus keratograph M5, you can actually measure the upper to lower levels, and you can tell exactly how high that tear meniscus is. Anything under 0.2 is considered an abnormally thin tear meniscus. And patients with a low tear meniscus height tend to have our aqueous deficient forms of dry eye, known as KCS and Sjogren's KCS. Why is it important to differentiate the type of dry eye? Because the treatments are not completely different. There's inflammation in both forms, but the focus on what you treat is different between the two. As you see in the next slide, you can actually take your little graph, your little bars, and you can line up the upper and lower tear meniscus. Your technicians would do this, of course, and give you an exact number. And if that number, again, is above about 0.3, you know you have a good, healthy, high, normal tear meniscus. And if it's sub 0.3 microns, then you know that this is abnormal and maybe an example of a aqueous deficient form of dry eye. So what can we do with the Keratograph M5, which is the question that the next slide adds? Well, you can do a lot. They have topography, contact lens fitting algorithms. You have ability to pick up on keratoconus, so many things. But you also have tear film and ocular surface assessment capabilities, which we just went into. And in fact, everything that's in the TFOS DUES-2 diagnostic recommendations, other than osmolarity, but as the recommendation said, you can do any two of those three that you want to do. You're actually going to find that it allows us to treat, as you see here, everything that we measure can be done on the Oculus Keratograph M5. Everything in this entire diagnostic algorithm exists in that one system. So other than symptom questionnaire, that we expect you would end up doing on your own. So why is that important? Well, the next slide is what we're going to talk about, which is treatment. When you're treating your dry eye patients, now that you've made a diagnosis, and Rendy is another really good system that goes through patient education, it used to be known as iMaginations, which is in 2 slides ahead. You'll see that that's important to educate patients, because you want to emphasize that this is a chronic condition and it is a progressive condition. Patients don't realize that. They might take it lightly until they end up in a clinic like mine with 5 glands left. So you really want to take the time to let them know why it's so important. And then TFOS DUES-2 has a series of steps that you can take. Education, as I just showed, was the first step. Modification of the environment, humidifiers, education about diet, and essential fatty acid supplementation. And I like how they said essential fatty acids. They didn't say omega-3s. In fact, some of the most effective omega fatty acid supplements are actually GLA-based, which is an omega-6 that converts to PGE, like you would get in GLA, Hydro-Eye, those sort of things. Identification of potential modifications, increased lubrications, lid hygiene, compresses like Bruder masks, those sort of things become very important. Step 2 in the next slide is when you finally start looking at what else could be going on. Is it blepharitis from Demodex? Should we be doing punctal occlusion? Should we be treating this with anti-inflammatories ranging from steroids to LFA1 antagonists to cyclosporin, and that they consider at stage 2. But I will tell you another way to look at what they said, if you go to the next slide, is to break down, like we said in TFOS DUES-2 diagnostics, the type of dry eye. If it's evaporative dry eye, the next slide will show you that the key components to Meibomian gland related dry eye, so this is evaporative dry eye at this stage, not just MGD, is to realize that that type of dry eye has 4 components: obstruction, inflammation, biofilm, and tear film instability. And this helps really understand why just using an artificial tear like the 4th bullet probably won't treat the disease, because you're missing biofilm, inflammation, and obstruction. But likewise, if I just put a person on lifitegrast or cyclosporin and I just treat the inflammation but not the obstructed Meibomian glands, they just keep obstructing. So I'm not getting the benefit. I'm not actually treating one of the underlying causes. That stays. And likewise, if I just treated the obstruction but left the inflammation, they're going to get obstructed quicker. Same thing with the biofilm, the blepharitis. So we have realized in our clinic that it's only when we treated OBIT, O-B-I-T, I guess kind of short form for obituary, meaning if you don't do this, the Meibomian glands will die. Obstruction, inflammation, biofilm, and tear film. So maybe we should have done O-B-I-T. Anyways, if you treated those 4, you probably are going to get very good success, because we found that as we started treating this in evaporative dry eye, our success rate went up into the 90%. But when I missed one of these elements, patients did poorly. And it doesn't take a lot. Imagine you had a mild dry eye. You looked at your kerograph, the meibography was level 1. Expression was turbid. You did all the other tests that showed high osmolarity. You had some breakup time on your kerograph that was evident with non-invasive. You have your staining in fairly, that's kind of a mild evaporative dry eye. I would probably just do a hydrating compress for obstruction and debridement. I would treat them with an omega fatty acid and or a topical. I would probably do lid scrubs, and I would maybe put them on oil-based tear. That's it. I got all 4 covered. I had severe rosacea, 6 glands left based on my kerograph meibography. Patient with tons of staining. As you see in this graph, I might actually move into, for obstruction, probably thermal pulsation. I'd probably do a Blefex for the biofilm. I'd probably put them on corticosteroids and then move them to lifitegrast or cyclosporin. I use oral doxycycline for inflammation. And for tear film, I might actually use something like an osmolarity lowering tear. So what you see in this next slide is my algorithm for managing evaporative dry eye. It's taken me about 23 years to figure this out. Now, actually, take that back. Probably started doing this about 7 years ago. So 23 minus 7, 15 years. Here's my algorithm for aqueous deficient dry eye, focusing on just 2 things, inflammation and tear volume. And so once again, I'm able to kind of choose the things that'll help this KCS Sjogren's type patient who may have that based on our algorithm for how to manage an aqueous deficient dry eye. But if I didn't have the Oculus kerograph diagnostics to be able to tell me who had dry eye and then the subtype of dry eye into aqueous deficient, as you see here, or evaporative dry eye, as you saw in the last slide, it'd be very difficult for me to get the right treatment. What if I did a compress for this patient who had perfect Meibomian glands? Well, it might keep her Meibomian glands healthy, but it's probably not going to treat the condition. Likewise, I can't go the other way with those other patient populations and put them on something to help with their hydration, like punctal plugs. I'm going to plug most patients with aqueous deficient, but maybe not as many with evaporative dry eye. So it really helps you to know how to manage these patients extremely effectively. Then as you look at the next slide, which is our last slide, I want you to keep this in mind. Dry eye is a progressive disease. Think of this like glaucoma. You'd never make a diagnosis of glaucoma and then say, we're going to wait until you've lost some vision and then we're going to treat you. Nobody does that, hopefully. But we do that with dry eye disease. We say, you know what, I think you have dry eye. Here's some artificial tears. I mean, artificial tears are beneficial. Don't get me wrong. You got to use them during the day. It allows for comfort. But look at the study on the slide. This was a study that looked at the pivotal trial for cyclosporin's first FDA drug approved for dry eye. The group that had an artificial tear, and this is a very good artificial tear that isn't available today, but is extremely effective. 39% of them, as you see in this next slide, actually progressed in terms of T cell concentrations, meaning the inflammation got worse, meaning they probably lost more Meibomian glands from inflammation. The disease progressed. You might have got scalloped eyelid margin. Staining went up just using artificial tears. So artificial tears are important, but this is a progressive disease if you don't treat it. But in order to treat it, you have to have the best diagnostics. You have to look at meibography. You have to be able to look at non-invasive breakup time. You should be able to monitor and match staining and see where that goes. You make your diagnosis, determine which is the type of dry eye disease, and then manage it based on that algorithm I just provided you. And if you do that, you're going to have an impact on the most significant population of ocular disease we have ever faced in optometry and ophthalmology, known as dry eye disease. Digital devices are making this a young person's disease. Technologies that are affecting blink causes problem. All what's involved in the understanding allows this disease to happen at a fairly early stage. Men are starting to see as much dry eye as women under age 34. It's still a patient population older that gets dry eye disease too. So this could be the most important disease you treat. I encourage you to take that far, but also take that far with the diagnostics you need to make it happen. Technologies that allow you to do meibography, non-invasive breakup time, tear meniscus height, everything in between, staining, redness, etc., will really help carry you as a clinician, and most importantly, your patients, to a level that impacts their lives, prevents the progression, and overall helps benefit everyone involved when it comes to dry eye disease. Thank you for the time tonight. I think we can open up to any questions. We have about 10 minutes from when we started. I'd be glad to answer anything that comes up.
Thank you, Dr. Karpecki, and thank you everyone for attending. Just a reminder, on your GoToWebinar screen, there is a text box where you can enter any questions you may have. If you enter them now, I'll be able to read them off to Dr. Karpecki. If you miss part of the webinar, or if there's anything you would like to go back and review, you will receive a link to this recording tomorrow. All right, our first question, Dr. Karpecki, is, are some of the conditions that cause dry eye-like symptoms more common in certain regions or patient populations?
Great question, and because in actuality there is a difference. Asian population tends to have a lot more Meibomian gland dysfunction. But what makes that question important, but also very difficult, is that dry eye is one of the only diseases where as the disease progresses, regardless of patient population, these symptoms diminish. I mean, if you think about glaucoma, as you advance, you get more visual field loss. If you have macular degeneration, as you advance, you lose more central vision. In dry eye disease, you actually get less symptomatic, but your staining, your signs, the breakup time, your osmolarity all elevate because the nerves downregulate. In fact, the patients with the worst symptoms, regardless of any of the subgroups, any classes, any races that have the worst symptoms are going to be the earlier to moderate dry eye disease patients. So even though there are subtypes such as Asian population does have a lot more MGD as a whole based on some of these longitudinal studies that are out there, overall, it depends on the severity of the disease. And the more severe, regardless of any of these subtypes, the most severe patients have the least symptoms, and the more mild to moderate have the most symptoms. So we really need to be catching the disease early so we don't allow them to progress where they get downregulation and the nerves don't work as well, and the disease advances to levels that are very difficult to manage.
Thank you. We have another question. How do we ensure patients follow their at-home care after office treatments such as BlephX?
That's a great question. And you know, that is so important because compliance is a major issue. You know, if you're a child and you learn to brush your teeth, you do it for the rest of your life because it becomes a habit. We don't learn to clean our eyelids with lid scrubs or use warm compresses as a child. So there's no habitual formation here. So compliance is a major issue when it comes to that. You know, what I tell patients is this is just like going to the dentist. I like that analogy, that if you go in and get a cleaning, you still can't wait 6 months and not brush your teeth and not floss and think that if I had another cleaning 6 months from now, I'm going to be fine. I tell them it's the exact same thing with your eyes. If we do a LipiFlow or an iLux or we do a BlephX, we clean up your eyelids, you've got to maintain it, just like brushing and flossing at home. I think patients seem to get that. The other thing that I kind of emphasize to patients is I try to take a picture, like you see with the keratograph here. I use the word anterior segment photography, one, because you can bill it as that, but number two, it's a great teaching tool. A picture is truly worth 1,000 words. If you can show the patient the image and you can tell them what concerns you about the image, you know, kind of point out, here's what's concerning to me, missing glands, atrophy, meibography, where 80% of the glands are lost, whatever it might be, and tell them the consequences of not maintaining a daily regimen, I think patients tend to be compliant. I've seen compliance by saying exactly that, showing them a picture, pointing out what I'm concerned about. When doctor's concerned, the patients will sit up. They'll look right at it. They'll think if the doctor's concerned, I better pay attention to this. And then I tell them the consequences of not treating it. This disease will progress. You won't be able to wear contact lenses. If it's blepharitis, you'll lose all your lashes. I mean, these are all true things. Most patients at that point, I mean, more than 50%, that's not great compliance, but I mean, it's probably 10% if you don't do that. Over 50% tend to say, you know what, I get that, and I've seen the image, and it's locked into my brain. I'm going to do something to maintain it every day. So those have been the few things that have been successful that I've tried so far. And I encourage you to expand on that, but to do something like that, because the question is excellent. There's very little compliance if you don't do some of these things like showing a picture on your Oculus or slit lamp as we just described.
All right. Thank you, Dr. Karpecki. I believe that's all we have time for tonight. I wanted to thank you everyone in attendance and who sent in questions. Thank you, Dr. Karpecki, for your excellent presentation and your added discussion at the end.
My pleasure, Michelle. Thanks for moderating it, for doing a great job, because my internet is almost all out. And as you were having to do so much of the work advancing the slides, and I thank you a lot. You did a great job. It's not easy to do that when you have 58 slides. You did great. I want to especially thank Oculus for putting on this program. And most importantly, thank all of those attendees who took time out of their busy schedule to spend an hour here learning about dry eye disease and working through the maze of dry eye disease, to ask such excellent questions and insights in that. It says a lot about you, and a lot about the success you're going to have in your practice and the impact you're going to have on patients. So thank you very much, and certainly happy holidays to everyone.
Great. Thank you again. This concludes the presentation. On behalf of Oculus, we wish you all a good night.